So now it's my pleasure to welcome Professor Jean-Louis Vincent from Brussels. He's Professor of Intensive Care at the Université Libre de Bruxelles, and is past president of the European Society of Intensive Care Medicine, and also past president of the World Federation of Society of Critical Care Medicine. He has, of course, produced a lot of papers in the domain, and one of his favorite topics is fluid management, and he will teach us a lot on the way on how to best manage fluids in the topic of shock. Professor Jean-Louis Vincent, the floor is yours.
Well, it's my pleasure to address this very important topic, one of the most important topics in critical care medicine. It's very difficult to assess the volume status of a critically ill patient. The patient very often cannot complain of thirst and may have various signs and symptoms that could reflect hypovolemia or hypervolemia. And indeed, critically ill patients often navigate between a lack of circulating fluids, hypovolemia, and an excess of circulating fluids, hypervolemia. And both are very bad. Both can result in multiple organ failure. And we can go from fortune to misery and vice versa. The answer to this difficult question of optimal fluid therapy cannot be too simple. Fluid restriction is dangerous. Of course, it will reduce edema. There will be less extravascular fluid, but it may decrease the oxygen transport to the tissues. It may impair healing, and it may result in multiple organ failure. So just correcting hypotension with vasopressors without taking sufficient care of the volume status is the big road to multiple organ failure and death. When should we give fluids? When we identify a clinical problem that may be attenuated by fluid administration. Practically, it is often arterial hypotension. It could be tachycardia. It could be oliguria. It could be decreased skin perfusion, as we heard before. There are some clues at the bedside that can tell you, perhaps this patient may benefit from fluid administration. And again, we should not miss that opportunity. With fluids, we want to increase cardiac output by increasing cardiac preload. And that can sometimes increase blood pressure, but most importantly, it can increase oxygen transport to the tissues. Too much fluid can result in increase in venous pressures with excessive edema formation. We don't want to give too much fluid. With vasopressors, we could restore tissue perfusion pressure. That's very good, but there is a risk of excessive vasoconstriction that may impair the circulatory status and altered tissue perfusion. We often say we give fluids to correct hypovolemia. It's more complex than that. Because in many conditions, like in sepsis, or after trauma, after surgery, there is an inflammatory response with vasodilation. So we need to give more fluids because the blood vessels are dilated. We need to fill the tank. And then, as we heard, we may have to give more fluids to increase cardiac output to supranormal levels, what we call a hyperdynamic or hyperkinetic state. We cannot do it by formula. We cannot just look at the patient and say, okay, the patient needs 1 liter or 2 liters of fluid. Even the fluid balance is not very good. Sometimes the patient received several liters of fluid, but it's not enough. So you cannot stop because the patient has already received 1 or 2, perhaps 3 liters of fluid. And edema, it doesn't help very much because edema can coexist with relative hypovolemia. In inflammatory states, the capillary membrane permeability is altered so that there is more fluid going into the interstitial space, but you still need to give some fluid to the patient to hopefully fill the vessels. And this is particularly true when there is hypoalbuminemia, when there are low albumin levels, resulting in a decreased colloid osmotic pressure. If you have a leak in your gas tank, you still need to put some gasoline in your car if you want to move. So you cannot say, I'll stop giving fluid because there are edema already. No, think that edema is like leak in the circulatory system. So edema does not exclude hypovolemia. So we must be careful about the use of the term fluid overload, or the patient is in fluid overload. I also say it from time to time, but then I think about it and I say, what do I mean exactly? If it's edema, it doesn't mean so much. Hypervolemia, that's another thing. When there is too much fluid in the vascular space, like in acute renal failure when the patient no longer urinates, that could be a problem. But think about the fact that an edematous patient may be hypovolemic. So we need to individualize our therapy and monitor what we do. And indeed, that's where the SOSD concept comes into play. The first phase is a phase of salvage. You just want to keep the patient alive. You open the bottles, as we say, and we give fluids rapidly. But soon enough, we will have to individualize the fluid administration and individualize it. That's what we will call the optimization period. And there is no single variable that will tell you that the patient needs fluids. Patients may be hypotensive, and yet they may not be requiring fluids. The patient may have tachycardia, and yet the patient may not require fluids. If you have a central venous pressure level available, the central venous pressure level, the CVP level, will not really tell you very well that the patient needs fluids or not. Well, yeah, we need to integrate variables. Yeah, we need to look at the degree of filling of the heart, cardiac output, the degree of tissue perfusion, and in the future, artificial intelligence will help us to identify the situations where fluid administration is very likely to be beneficial. But in the meanwhile, we need to test the system. We need to use a dynamic evaluation. And this is primarily the fluid challenge technique, when you try to give some fluids and you see how the patient responds. Now, if the patient is mechanically ventilated, deeply sedated, anesthetized, then during the changes in intrathoracic pressures imposed by the respirator. You could look at the pulse pressure variation and the stroke volume variation. The fact is that if the patient does not have enough fluid on board, the blood pressure will fluctuate throughout the respiratory cycle. And you will see it on the arterial pressure tracing, or if you have a cardiac output monitor that allows you to look at it, you could look at the stroke volume variation. That should not go over, let's say, 12 to 15%. If it's below 12 to 15%, maybe the patient will benefit from more fluid administration. But this is only during mechanical ventilation with deep sedation anesthesia. It works very well in the operating room, and there shouldn't be major arrhythmias. So on the Frank-Starling relationship, it would indicate that throughout the respiratory cycle, the stroke volume can fluctuate depending on the amount of blood returning to the heart. Now, could we look at other variables during mechanical ventilation, like respiratory variations of inferior vena cava? It doesn't work very well. In some studies, it works well, and in some studies, it does not work well. This is a good meta-analysis of this approach. And you can see when you go up and to the left, it's good. Good sensitivity, good specificity. But sometimes in some studies, it's like flipping a coin. It does not tell you anything about fluid responsiveness. And even if you go to the superior vena cava using transesophageal echocardiography, it's not very good, even in sedated, paralyzed patients. The area under the ROC curve, as we call it, is hardly 0.75. So, in all cases, when there is a doubt, we need to test the system. That's what we call the fluid challenge. And the fluid challenge technique has been known for literally centuries, almost 2 centuries. This is one of the first descriptions during the cholera epidemic of a patient who is obtunded with signs of poor tissue perfusion. They give some IV fluid, the patient wakes up and starts to be jocular. Oh, I feel better. They stop giving fluid and the patient goes back to sleep and to shock. It's an amazingly good description of the acute effects of a fluid challenge. So please note, if you want to know the effects of fluid, you need to give a bolus. You cannot just increase the amount of fluids giving over the next hours. And keep this graph in mind. What you want to have is an increase in cardiac output. That's what you hope to get. And what you don't want to have is the increase in cardiac filling pressures. But there will be some increase in cardiac filling pressure. As I tell my students, when you go to a restaurant, you want to have good food, good drinks. That's the increase in cardiac output in a way. But at the same time, you know that you will have to pay the bill at the end of the meal. When you give fluids, there is some increase in cardiac filling pressures. So we should monitor both if you really want to have a fluid challenge. The fluid challenge is not a technique that will encourage you to give more fluids. No, It's a technique that will encourage you to stop giving fluids if the patient does not benefit enough. The elderly patient with severe cardiomyopathy, that's the good candidate. The young person with traumatic shock, you open the bottles, that's fluid loading. Very different. So optimally, you should measure cardiac output and a cardiac filling pressure. Today, it would be a central venous pressure with all its limitations. Remember, we are not looking at absolute values. We are looking at changes in cardiac output versus changes in CVP. I want to know how much more good food I could have if I am still hungry, and I don't want to pay too much for that food. There is a benefit and there is a cost. That's the Frank-Starling relationship. That's a very simple physiologic basis for fluid administration. So optimally, we would like to measure cardiac output during the fluid challenge to see if it increases or not. Are we still hungry or not anymore? There are various tools for this. We will not discuss this during this presentation. We can use the technique we like. We could even use the velocity time integral by echocardiography. We must be careful. It requires a little bit of expertise, but it's definitely doable. You could perhaps look at simple variables like, is tachycardia due to hypovolemia? If yes, the heart rate will go down during fluid administration. Or what about the blood pressure that could go up in the hypotensive patients? Well, that works well in trauma, as we alluded to before. In traumatic shock, you give fluid, the blood pressure goes up. Now, in septic shock, it doesn't work so well because there is vasodilation, decreased vascular tone. And then, as you can see on this graph, the blood pressure may not increase very much, even though cardiac output may increase. That's what we showed 8 years ago. In some patients who respond to fluids, there can be an increase in cardiac output without major increase in mean arterial pressure. So if cardiac filling pressures do increase with fluids, we also need to appreciate the price to pay, the risks. If the central venous pressure is low, if there is no major respiratory failure, no big risk. Maybe not a fluid challenge, let's have a fluid loading. But if there is severe respiratory failure, like in severe COVID, for instance, it's the situation where we should do a fluid challenge. And if there are any questions about the benefit of fluids, we should go for dobutamine to increase blood flow or blood transfusion to increase the oxygen content of the blood. Very briefly, a fluid challenge can be done over a very short period of time. Yeah, but this is true primarily in the operating room, where things really change from 1 minute to the other. And there we can use 100 cc's of crystalloids to predict the degree of fluid responsiveness. Maybe even a shorter period, 10 seconds. But in the ICU, you would like to allow some time in order not to destabilize the system too quickly. But on the other hand, we should not do a fluid challenge over 30 minutes, as we sometimes hear, because then there are so many other factors that could influence cardiac output. We would no longer know if there is a change due to fluids or a change due to something else. So optimally, we should give the fluid in 5 to 10 minutes and it should be 100 to 200 cc. Could be crystalloid. We should define the clinical objective. Optimally, it is an increase in cardiac output, except maybe in trauma or in severe heart failure, where we look at simply the blood pressure. And of course, there are some safety limits, which is usually a maximal central venous pressure. And during the 10 minutes period, or 5 to 10 minute period, nobody should touch the patient. Otherwise, we don't know how to interpret. Otherwise, there are so many elements that could account for a change in cardiac output. So in summary, if stroke volume increases, two options. Either the filling pressures increase reasonably and okay, we can continue. Oh yeah, there is a benefit and the risk doesn't seem to be major. Now, if we feel that the filling pressures increase substantially by 2, 3, 4 millimeters of mercury, we stop. The risk is too high. If the stroke volume does not increase, the filling pressures increase, the heart does not tolerate the fluid. We are on the plateau portion of the Frank-Starling relationship. Stop. If the stroke volume does not increase and filling pressures do not increase, did you really give fluids? Where did the fluid go? Well, maybe it went via the urine output into the urinary bag, because otherwise, if fluids remain in the vascular space, something should happen. And if we decide to stop fluid administration, yeah, then we have the option of increasing vasopressors in case of shock, or add a little bit of dobutamine if we think that the cardiac function may be inadequate. We may have to repeat the fluid challenge regularly, as shown in this multicentric French study. It's very often transient, so you may have to repeat your fluid challenge over time, of course. So a fluid challenge, it's not 500 milliliters. It's not 500 milliliters in 30 minutes. It's more 200 cc's in 10 minutes, although you need to evaluate the host response, the patient's response. If you don't do that, how can you make sure that this was indeed beneficial? How many patients will respond to a fluid challenge? It depends on your population. This is a question which is not relevant. If it's around 50%, that's good. It means that indeed you were about to flip the coin and 50% of the patients responded. Good. 50% of the patients did not respond. Good. Don't give fluids to those who do not respond. Now, could we do some kind of an internal fluid challenge? That's the passive leg raising test. It's very smart to bring fluids from the legs and the abdomen into the thoracic compartment. It's a transient effect, but we could document the effect of this shift in fluids in the body. The big problem is that today we no longer sedate our patients in the ICU. So it's a stress. If I come and if I raise your legs at the middle of the night in your sleeping room, you will not be very happy. Your blood pressure will increase. Okay, we would not look at blood pressure. We should not look at blood pressure during the test. It is very important. But if there is an adrenergic response, there will be an increase in stroke volume during the test. So read this paper, which is very well written by Monet and Teboul, who are the world expert on this. They say, wait a minute, do not simply measure blood pressure. You need to look at the transient change in stroke volume. So you need to have the appropriate monitoring system to quickly assess the changes in stroke volume. Avoid adrenergic stimulation. You could also look at the microcirculation, as Daniel De Backer has shown with us, or as it has been shown more recently by Kaboul and others in the operating room, but this is more for research today. So the point is, the fluid challenge technique should encourage you not to give fluids when the patient does not benefit, and the passive leg raising test has the same aim, to avoid giving fluids when it's not necessary. I think I will skip that because I see the time running. I will not speak about the type of fluids. Let's reiterate that we need to start fluid administration when we identify a problem that could be resolved or attenuated with fluids. If there is an excessive risk-benefit ratio, we stop. We need to monitor the response. So now very quickly, we arrive in the stabilization period. Now we no longer optimize fluid administration. We can now look at edema and be worried about excessive edema. Now, in this phase, we could try to reach a negative fluid balance, increasing diuresis with diuretics or with ultrafiltration if the patient does not respond to diuretics, furosemide. In this large multicentric study, we could show that the prognosis is worse when there is a very positive fluid balance over the first 72 hours. Look at the bottom of the slide. It means that during the first 24 hours, don't give diuretic for edema. No, 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 no. It's when you reach the stabilization phase that you can afford giving diuretics. Don't give fluids and diuretics at the same time. That doesn't make sense. Initially, you give fluids if you feel the patient may benefit from it, and then you give diuretics because you want to avoid hypervolemia. Now the patient will lose weight. This is very interesting. If the patient does not make urine, you need to use ultrafiltration with the hemofiltration or dialysis. But we must do it properly. Look at the first author, Dr. Wurugan. He published this paper showing that if you do not ultrafilter enough, if it's less than 25 cc's per kilogram per day, there is an increased mortality rate. So hypervolemia is bad, okay? Well, a little later, the same author published this paper where he showed that if you ultrafilter too fast, you may increase the mortality rate. So there is also a way to do it. You cannot afford hypervolemia for a prolonged period of time, but you do not want to remove fluids too quickly, as this may be poorly tolerated by the tissues. So you see, we need to personalize our therapies. Consider the yin and yang, the benefit of fluids in some patients and the risks in all patients. We need to consider the clinical problem and keep it in mind. Who needs the fluid loading? An excessive amount of water in the body is associated with worse outcomes. We will look at the edema when the patient is stabilized, not before. To summarize, the presence of edema does not exclude an insufficient blood volume. We give additional fluids only when there is an identified reason to give fluids. If the patient is possibly hypovolemic, we do not increase the maintenance fluids. We give fluid boluses, but we monitor the patient's response, assessing the benefit, yes or no, and the risk, how much. And if fluid administration does not benefit the patient, stop it immediately. Do not feel encouraged to continue to give more and more fluids. Think at the SOSD approach, as the time factor is important. Identify the problem, evaluate the risk-benefit ratio, and monitor the patient response. It's not easy, but it's fundamental, as this can have an impact on patients' outcome, on organ dysfunction, and even mortality. Thank you.
Thank you very much, Professor Jean-Louis Vincent. It's a very nice and illustrative talk on the principle of fluid management in critically patients. Just one question. What do you do when the effect of the fluid loading by the fluid challenge is positive but transient? And you have to repeat it, and then you repeat it again. And so at what time do you decide to stop, to give volume, and to switch to another alternative, even when the response is positive in a given patient?
That's a very important question. It's true that in some patients, you need to potentially repeat the fluid challenges every 10 minutes. It's almost a continuous fluid challenge. And that is problematic. Why does it happen? It's not entirely clear. Some people say, oh, it's because there is extravasation of all the fluid you give. Well, that does not convince me, because extravasation does not take place so quickly. But there could be a distribution of blood. There could be some other elements, and maybe a little bit of increase in cardiac filling pressures, etc. The point is that at some point we need to look at other elements. And what I do at that time is to look at the SCVO2, the central venous oxygen saturation, because if it's high, it is a clue against further fluid administration. It would be in favor of just vasopressor therapy and nothing else, and not giving more fluids. But in some patients, you still need to cool down your fluid administration if you see that the effects are very transient. Consider vasopressors only, consider adding a little bit of inotropic agents. These are challenging cases, but we sometimes find them.
Okay, thank you very much. I think that we have to move on to the next presentation.